So the calcium function. So first you can uh, go for the homeostasis, how it is done, and then come to the function. You can just write skeletal mineralization, blood coagulation, neural transmission, plasma buffering capacity, enzyme activity, maintenance of normal muscle tone, excitability of skeletal and cardiac muscles. All these things are the normal function of the calcium. Coming to the homeostasis, uh, there are two things. Whenever the blood calcium level is rising, stimulus is rising, from thyroid gland you get calcitonin getting released, which will act on the kidney to reduce the calcium reabsorption from the kidney and make more calcium get deposited in the bones. So these are the two simple mechanisms by which calcitonin will utilize the excess calcium that is going beyond the normal level by allowing it to get excreted by the kidney or get it deposited in the bones. So that is the simplest way of understanding the elevation or normal maintenance level by whenever there is a rise in the calcium level. On the contrary, when there is a level uh, falling, the level of the calcium is reducing, then parathermone comes to action. Parathyroid gland releases parathermone, and parathermone releases calcium from the bones because that is where it is normally stored. And opposite to that, not allowing much calcium to get excreted by the kidney, it is reabsorbed, and through activating the vitamin D, it enhances the absorption of calcium from the intestines. So all of us should know that these are the three locations: bones, kidney, and intestines. It's very important for maintenance of the normal level of the calcium. So both these mechanisms, this simple picture will tell you how the homeostasis is done, which is about 100 milligram per deciliter, and these are the functions. So this simple picture and this bullet points will tell you the function. Now, coming to the causes hypercalcemia, and of course he has nicely elaborated all the various functions, how they are done at each and every level. Now coming to the abnormalities, hypercalcemia, all these things, of course, bones, horns, and all that the mnemonic to remember that. But what are the causes of hypercalcemia? It can be primary hyperparathyroidism, malignancy, pseudo-hyperparathyroidism, renal failure, Addison's disease, hyperthyroidism, and immobilization. All these things lead to increase in bone calcium reabsorption, and mechanism is by increased parathermone, osteolysis, and albumin and bone resorption, all these things. And hypercalcemia due to decreased urinary calcium excretion. That can be in familial hypercalcemia or hypocalciuria, thiazides. And this is due to GI tract. So these are the three locations. From the bone, more calcium can be resolved, or it can be by decreased excretion by the kidney or increased absorption from the GI tract. So very easy to remember the mechanism how calcium levels can go up and various categories or the causes for them. How do you manage that? Hypercalcemia management, you can classify that into mild, moderate, and severe. The mild is 10 to 12, moderate 12 to 14 milligrams, and more than 14 is severe. And for mild, usually they are asymptomatic. So no medical management is needed. Avoid thiazides, lithium, high calcium diet, volume depletion, and prolonged inactivity. And if it is moderate and if they are asymptomatic, again nothing need to be done. But if they show symptoms of bone pain, groins and moans, or psychological disturbance, intravenous normal saline plus bisphosphonates can be given. And if it is severe, then you go for saline. Calcitonin also is available, and sensipar, furosemide, bisphosphonates plus recurrent hypercalcemia, very severe hypercalcemia, 18 milligram per deciliter, or parathyroidectomy. In severe resistant cases, you have to remove the parathyroid gland itself by surgical measures. And antibodies are there, denosumab or hemodialysis also may be required. So this is how we can classify the management instead of simply saying that the normal alone. So I have not talked about hypocalcemia, which is quite common after thyroid surgery. So before thyroid surgery, all of you should remember that estimation of calcium is level, calcium level is very important, because total thyroidectomy invariably results in inadvertent removal of the parathyroid gland also. So post-operatively, even on the table, sometimes patient develop hypocalcemia, and that may lead to laryngospasm, as he has mentioned in his slide. So that may be the cause of the airway problem in the immediate post-op on the table itself. So unless you have documented the calcium level preoperatively, you cannot compare it in the post-op phase and identify and try to. So don't think that hypocalcemia can happen only after 24 hours. It can happen even on the table in some cases. So it has been documented and recorded. So you have to be very watchful about that also. Right.